Very good evening to all the delegates. I am Dr. Kumar. I head Medical Affairs for Chronic Vertical. And on behalf of my entire team in Dr.A.Sreenivas, and along with our prestigious associations, API, ICC, as well as Asia Pacific Vascular Society, I warmly welcome all of you for the first official launch of India's first cholesterol goal awareness icon. As you all know, this is a National Cholesterol Awareness Month for us, and it is our proud privilege that we have been able to associate with such a prestigious associations to take this cause forward. As you all know, normal lipids are one of the biggest risk factors for the cardiovascular diseases. This has been shown time and again through the Interheart study that was published in Lancet. At the same time, we also know, with the help of some of the large-scale studies like CTT collaboration study on the statin trials, that suggests that if 1 millimole per liter reduction in the LDL cholesterol is associated with around 10% reduction in the major coronary events, and other major events were reduced by 25 to 15%, for example, stroke. Hence, it becomes very important for all of us to look at dyslipidemia with all the seriousness and aggressive treatment. Our goal in Dr.A.Sreenivas is good health can't wait. And we live by this mission. This is very well reflected in our commitment to act with speed to find innovative solutions that addresses the unmet needs, in this case, the dyslipidemia management, and to accelerate the access to much needed medicines for the people around the globe. We are present with all the major regions of the world. We are present in more than 30 countries. We have 10 API manufacturing facilities, 14 formulation manufacturing facilities, 10 global R&D centers, and 1 biological development center across the globe. Our strong presence across the specialties and the therapy areas is shown by our in-licensing deals with many of the innovator companies like Amgen, Ferrer, and likewise, and our rich product portfolio, which caters to the unmet needs of the patient across 20 specialties and 15 therapy areas and 30 disease areas. We work with our partners to make innovation accessible to our patients through 20 innovative in-licensed products that we have. So coming to the innovative programs, we are proud to have these programs which we do every year. There are more than 25 flagship events that we do that covers nooks and corners of the Indian continent and the various therapy areas. So to name some of the programs, we have Lead Forum, we have Advanced Hypertension Academy, we have Hypertension Congress, the Inside Meeting for the cardiologist, and Epilepsy Conclave, for example, for the neurologist. So we take pride in this because it's a confluence of the top KOLs across the globe with our national experts, and then percolated down to the practicing physicians to improve patient outcomes. So why are we celebrating National Cholesterol Awareness Month? So as I already touched upon, it's a very important subject. There's a lot of pressing question whether dyslipidemia in India is aggressively treated. As we all know, dyslipidemia in India is seen as early as in younger population. The prevalence of CAD risk in India is around 11% for non-diabetics and 21% for diabetic patients, as compared to the US, where it is just 2 to 3%. Hence, there is a greater need than ever before for us to bring all the experts together through a common platform to share and exchange ideas for dyslipidemia management to improve outcomes. I'll not take much time. I'll just quickly get to the quick introduction of the esteemed faculty here who actually needs no introduction, with decades of experience under their belt. It's my proud privilege to welcome Dr. Khanna, who is the group advisor for the Apollo Group of Hospitals, the past president ICC. He is the past chairman of the National Interventional Council for the CSI. He is the chairman for the Asia Pacific Vascular Society, and he has published more than 35 book chapters, and he has traveled all across the globe for the national and the international conferences. Welcome very much, sir. And it's my proud privilege to welcome Dr. Arul Raj, who is a senior physician with more than 3 decades of experience, National President API for 2020, former API Academy, and he has been instrumental in growing and strengthening and disseminating science to the members of the API. He is the first Indian to be elected as the president of the Commonwealth Medical Association for 2007 to 2010, and he has been a prestigious BC Roy National Awardee. Welcome, sir. It's my privilege to also introduce Dr. Raghu. He is the professor of cardiology at the Dr. Jayadeva Institute of Cardiovascular Sciences. He is the vice president of ICC, vice president CIC Bangalore chapter 1999 to 2000, and he also has a lot of publications under his belt, and he has been a part of national and international faculty. Welcome, sir. And last but not the least, Dr. Sreenivas Kumar, welcome, sir. He is the senior consultant cardiology at the director cardiology and the clinical research in the Apollo Group of Hospitals, Hyderabad, professor of medicine at the Apollo Institute of Medical Sciences, chairman FACT Professional Society, and founder director of the FACTS Foundation, Fraternity of Advanced Cardiovascular Techniques and Solutions. He's also the founder director for the TCT Indian Conference. And he has been the chairman for the CSI chapter and the past president of the APCSI. Welcome again, sir. And without taking much time, I'll now hand over to Dr. Khanna for the context setting for the National Cholesterol Awareness Month and why it is so important for us. Over to you, sir.
Welcome all of you. It's been a very great pleasure to be associated with the API and the ICC and also with Dr. Reddy. And I must congratulate Dr. Reddy for actually bringing out this concept. It is such a unique concept being practiced for the first time in the country. And I must congratulate Dr. Reddy for this foresighted efforts. I welcome all of you to this event. I also thank API and ICC for collaborating for this particular initiative. We are here today to celebrate National Cholesterol Education Month initiated in India for the first time. As all of you know, this lipidemia incidence and prevalence is very high in India, and India being a capital for that also not in a good sense. And thus we are also the capital of cardiovascular disease. And if we can control this lipidemia at a proper age and with the proper optimal medication and lifestyle, we can actually control cardiovascular disease. The prevalence of cardiovascular disease risk in Indians living in India is about 11% for non-diabetic patients and 21.4% for diabetic patients, while it is in US it is just 2.5%. They have worked hard on it, and we are actually going the wrong way. We were going the wrong way, and we are also genetically most predisposed. Now, high cholesterol, high LDL, and triglycerides are the key risk factors and should not be ignored, as one has to pay for it if this is ignored in the initial stage. And we know, as Dr. Kumar said, the disease starts very early in stage, even in the childhood or early teenage. Also, there is an Indian study which was published and presented in the American Diabetic Association Congress in 2019. That is the lead study. And as per this study, 9 out of 10 very high-risk patients are not on the achieving the lipid goals in India. And hence, it is very important to take a strong initiative for lipid goal achievements in this lipidemia patients. Though US is having lower incidence and prevalence, but they have initiatives like National Cholesterol Month, which for the first time we, Dr. Reddy's initiative, we are doing it in India starting from today. The US is having it for last many years, in spite of having a very low incidence of dyslipidemia, to spread the awareness. And we are going to do the same in India, as such initiatives were never done before. We all, that means all 3 participating associations, which is the API represented by Dr. Raj and the ICC represented by Dr. Raghu, with Dr. Reddy's, decided to take this strong initiative in this regard and took an initiative of declaring September as a National Cholesterol Education Month. I hope Dr. Reddy continues with this initiative in further years, and maybe the government also takes this cues from this and declares September as the National Cholesterol Education Month for subsequent years. Now, I would like to invite Dr. Raghu and Dr. Sreenivas and Dr. Arul Raj for panel discussion on how we could ensure that patients achieve the goal and facilitate the overall improvement in India with this lipidemia. We would also discuss on what we could do at our level and what we could be done at the patient's level to improve the overall situation in India. So this would be a good context setting to start the discussion. There would be more questions, but I would leave it to Dr. Kumar. I think the flow of the program would be probably a presentation and unveiling of the logo, and followed by this panel discussion, if that is right. So over to you, Dr. Kumar.
Sir, thank you so much, Dr. Khanna. Now I would request you, along with Dr. Raghu, Dr. Arul Raj, and Dr. Sreenivas, have a quick panel discussion. And the questions are already shared with you. So we'll have a brief panel discussion before the unveiling of the logo. So over to you, Dr. Khanna, for moderating the panel discussion questions. So we have two rounds of panel discussion. One would be before Dr. Sreenivas, one would be after. So over to you, sir.
Okay, so now once we have such a distinguished faculty, Dr. Sreenivas Kumar, Dr. Raghu, Dr. Arul Raj, and three societies which are participating here, I would just set in the context with three questions. Why cholesterol awareness is important, and did we see any improvement in it? And just to give you a brief introduction, that Interheart study, which was done in about 52 countries all across the world, India was a major participant there, showed that high cholesterol contributes to about 49.2% of cardiovascular disease. And recent studies have reported that cholesterol is present in high cholesterol is present in 25 to 30% of urban and 15 to 20% of rural subjects. And this prevalence is lower than high income countries or advanced countries. So the guidelines have reduced the LDL-C cholesterol goals, going for lower the better concept. There is a hesitation in aggressiveness of treatment of this lipidemia among Indian patients and also at public at large. So I would invite one by one, maybe first Dr. Raghu. What would your comment be on this? Why do we think that cholesterol awareness is important in our Indian setting? And what actually we can do to see improvements in achieving lipid goals in India?
Yes, Indians have got higher lipid levels compared to Western population, probably with a lower socioeconomic status also, as you told. Almost 25 to 30% in urban population have hyperlipidemia compared to 15 to 20% in rural population. And at young age, we see a lot of people with high LDL cholesterol, and probably in Indians have high triglyceride and low HDL also. And we are more prone, genetically, we are more prone to higher incidence of cardiovascular events. Probably that's why we Indians have got almost 3 to 4 times higher incidence of cardiovascular events compared to urban, probably Western population. And awareness of hyperlipidemia is not very high in Indians. Probably we are not aware. And also, as a physician in the family practice, we are not aggressively treating lipid levels. That is one of the problems. Probably there is no awareness regarding the risk factors for cardiovascular events.
Dr. Arul Raj, who is the president of the Association of Physicians of India and a very, very eminent physician. And I would like to know what is your view on this, and is there a need? Why are we not able to achieve the lipid goals in India, and what can we do for better awareness?
Thanks, Dr. Khanna, for the setting given and the leading the discussion. See, all of us know that cholesterol and its various components cause, endothelial dysfunction and plaque. That is known. Though the levels we have been set at some level and then we are bringing it down and then subdivision, support-lipoprotein, everything is coming up. We also know that the incidence of dyslipidemia, mostly on the cholesterol side, is very bad in Indians, Asian Indians. Whichever part of the world they are, it is bound to be high genetically, and they are more prone for, vascular diseases, whether it is cerebral, cardiac, cerebral, renal, peripheral, anything. But why this is not? There are a lot of efforts to control. We are sticking to the guidelines, and we are trying our best to bring down. Why it is not still coming down? The major stakeholder in bringing down the lipids is the patient himself or the public, and public has to be better educated. That is what I feel. We did a lot of efforts on diabetes control through the public and through the WHO. But still, though it has reached the public, it is still not effective. Not bringing down effectively. But at least today, people are conscious of it. Whereas this lipid level still has not gone into the minds of the common man. As all of us know, as WHO has said, the common cause for this is physical inactivity and an unhealthy diet, which is not in the plates of pharma or the medical profession, which is in the plate of the common man or public. Now it is our duty, the professional associations and the healthcare professionals and then industries to reach to the common man. WHO, APA has adopted the project as APA Heart. It is bringing down the incidence of coronary artery disease in our great nation by controlling diabetes, hypertension, and to which I have added lipids. Now, my conclusion should be the major stakeholder here is the public, common man. He or she should be made aware. Your cholesterol has to be at this level. Why? Otherwise, you will get a cardiac problem or a cerebrovascular problem. These are the methods to keep it down. All of us know diet and physical inactivity are the major factors in our Indians. We keep sitting down and keep eating and putting up our belly. Now this has to reach through all the stakeholders, government, professional association, and then medical professionals, and then the industry. That's my view, Dr.
Dr. Sreenivas, your views on this?
Yeah, congratulations, Reddy's, for this initiative of cholesterol month, and a lot of initiatives, many such more are required to create increased awareness on cholesterol. A lot of awareness is created as thanks to physicians and endocrinologists and diabetes, but I would feel that not even 1/10 of it is created for cholesterol. So anything which is done on this front is most welcome. We can do multiple initiatives to increase awareness of this important problem. Surprisingly, if you see Interheart study and many other studies, 90% of the problems they said is related to cholesterol, which is very least really bothered to by patients as well as some of the doctors. Though it is increasing, such initiatives are coming up. Of late, it is increasing. Part of the reason why this gets confused is it is not hyperlipidemia. It is not very high cholesterols which are common in our country, but it is more like a dyslipidemia, like abnormal low HDL, increased triglycerides, and probably borderline LDL and borderline total cholesterol is what we see in our country. And but one thing we need to understand is whatever lipid values our patients have, that itself is abnormal for them, and that itself is leading to myocardial infarctions and ACS for them. So that's how the latest modification of 50% reduction of the pre-existing values with high-intensity statin is also very pertinent and relevant to our country. So not only the absolute values, what we need to highlight to the public is whatever values we have, that itself is atherogenic our Indian subcontinent. Being Indian itself has its own risk, and that's how I think it's very important to increase the awareness on the subfraction abnormalities too. And probably in India, what we have is that atherogenic dyslipidemia type of combination, which is high triglycerides, low HDL, is very common in our country. I think with this, we can have further discussions after the talk. Over to you, Dr. Khanna.
The other very important thing is I'm not sure, and to the best of my knowledge, do we have any societies or any guidelines working on this, Dr. Arun Raj and Dr.
So
Raghu?
Lipid
Yeah,
Association of India.
Lipid Association of India is bringing out, already has brought out the, guidelines.
I will present that, Karna sir.
Okay.
Yes. And Dr. Raghu,
I think we can go to the talk later. We can discuss other things. Otherwise, it will be repetition. I think whatever Dr. Sreenivas Kumar can discuss the talk, then we can take up the questions. I think
They want to unveil that
logo.
Okay, you want to do that before?
so
Or
we will probably talk about how to increase. Is Srinivas, are you going to talk about how to increase the awareness in general public about?
No, that is not that sort of thing. It's only scientific discussion is covered in my talk.
That was the third point of our discussion here. Discussion: what should be done to actually increase the awareness of dyslipidemia and management of dyslipidemia and the goals? So that's very important if you really want to achieve something. That is very important.
One thing that probably we should have this in the textbooks, probably in high school and colleges, some chapters about lipid abnormalities, what is the impact on health, like hypertension, diabetes, all these health related issues should be included in the school level. That gives you a lot of awareness to the children. In turn, they can talk to the parents. I think that's where we are lacking probably. Textbooks which deals with health related concepts, probably environment, maybe diabetes, hypertension, ischemic heart disease, lipid disorders. All these factors should be probably, we should have one chapter in 5th standard, 6th standard, 7th standard. Probably a lot of children will be aware, then in turn it can be, whole family can be benefited. That's one thing. Probably whatever the pharma companies and association like Lipid Association, CSI, ICC, we can also have a lot of public awareness talks, alliance, Rotary Club. All these should be involved in day-to-day awareness of all these problems.
Dr. Arul Raj, what's your comment on this?
Yeah, I totally agree with you. This is what I stressed. See, the major stakeholder is not doctor here. We are educating the doctors about the varied levels and the levels which have been set for, total cholesterol, HDL cholesterol, LDL cholesterol, triglyceride, and its relations, all those things, the levels are being highlighted to the doctor at what level it should be kept. But ultimately, unless the patient supports, the result is not, achieved. And we should go all out. I support Dr. Raghu. We should go through the, civil society organization. In all these areas, now diabetes has gone very much depth into it. Now hypertension is going. Diabetes has gone to the, level of in utero, intervention. Now they have started talking about it. Now probably a stage should come for lipids in vitro. The food that mother takes, it has to be controlled. Probably to that level we should come. I totally agree with you that it should be put into the, curriculum of, the school curriculums. Now the new education policy has come, doesn't talk anything about it. But we should press and then see that it goes in, so that right from their age they are put on. They should not overeat, they should not take fat, they should do some physical activity, and they should get it checked right from the age of 20 and periodically check it, see that they should keep it, at this level. And why also we should say that if you want to prevent the incidence of a vascular event in any territory, I totally support, and I am of that strong opinion. All the industries who are manufacturing the various products to control the dyslipidemia has to have a opening to the society also, and they should also reach to the society. That way we'll be able to definitely bring down the incidence to our expectations.
True. That's a very, very powerful statement, and I think I totally endorse that. And probably what we should do, not only in the schools, but every society, every curriculum, whether it is arts or whether it's science or it is in school or medical science or engineering, there should be some sort of orientation program that, because we are dealing with individuals and they move forward and have their own families, this sort of basic training has to be a part of every curriculum. And the National Educational Society definitely should have actually, the policy should have actually looked into this. but still it can be amended, and I think it will be a good way that we can have a combined sort of a suggestion to them that they should put this into every curriculum, whether and across the specialities of teaching. That's very important. And also every special, I mean, in the hospitals also, it's not that only should be specified in cardiology or medical OPDs or patient. It should be across the, I mean, when the patient enters the hospital or healthcare facility or a diagnostic facility, these sort of educational material should be freely available, and it should be well advertised, that people know across the society that these are the risk factors, this is what you get, this is how you prevent, and that will be a great thing if this can be done there.
Another thing, Dr. Khanna, is many doctors themselves and many very highly reputed and eminent speakers also keep talking crap about that cholesterol treatment, statin is not good, and then cholesterols are okay for the body, and all that stuff goes on. And unfortunately, anything negative thing, criticisms get published and circulated very fast in social media and everywhere. We should also try to do something to curb this menace on this awareness of cholesterol, and probably putting somebody, a good brand ambassador like person who is healthy and sports, or somebody to create awareness and public will also go a long way in educating and stressing the importance of cholesterol in disease production.
Sure. So thank you, Dr. Khanna, and thank you all the esteemed experts. Great points, some really great points for us to take key messages. So now this is the time to cordially invite all the esteemed faculty to officially launch India's first cholesterol goal awareness icon. And for that, I would invite Dr. Arul Raj, Dr. Raghu, Dr. Khanna, Dr. Sreenivas, and from Dr. Reddy's, Mr. Ashish Nigam, who is the cluster head for Chronic Vertical 1 for Dr. Reddy's. And since we cannot have lamp lighting here, I would request all of you to put your thumbs up and tap to unmute when this video plays, so that it becomes official launch. So, Amrish, if you can play the video.
If you are not able to see any video.
Thank you all for the endorsement to take this cause forward. And now I would invite Mr. Ashish Nigam to share his thoughts on the icon launch. Over to you, Ashish.
Yeah, so thank you, Dr. Kumar. Good evening, doctors. I think first of all, let me thank all the doctors who have contributed their time today for this iconic event. I'm sure that your association with us in spreading awareness on cholesterol goals shall be highly valued. We also would like to thank all the three reputed bodies for helping us make this program possible. Last but not the least, I also thank all my speakers, analysts for today's program. As this is a National Cholesterol Education Month, we are going to have two more national level events on 15th and 26th September in association with API, APVS, ICC, and we request you to be the part of all the upcoming events for the month. And let me also assure Dr. Anil Khanna, when he wanted to talk, when he expressed his desire that can we be Dr. Reddy's will be a regular partner. I just want to assure you one thing. We partnered with API some 8 years back, and Dr. Aluraj will knows that 8 years back, along with API, we rolled out an initiative for all the physicians of India called as E-Hypertension Academy. Now later on it becomes Advanced Hypertension Academy. And 8th year in a row, today even under the leadership of Dr. Aluraj, we are continuing this initiative. We never stopped it. So that is our commitment towards helping our physicians upgrade their skills and knowledge as per latest things. And I assure you that we will definitely scale it up. We will improve it as per your suggestions and your three body suggestions. So I thank you very much once again. Thank you.
Thank you, Ashish, for that good lecture and good commitment from our side as to forward the cause of dyslipidemia management. So I would now invite Dr. Sreenivas for without any further wait, talk about a lecture on get to goal, begin with risk stratification. And Usha will be heading the proceedings. Yeah. Over to Dr. Sreenivas.
Yeah, good evening, all of you. And thank you, Reddy's, and congratulations to you all for this new initiative of cholesterol awareness creation month, being September. And September also, I think, happens to be last Sunday, happens to be World Heart Day. It's also relevant that cholesterol awareness month is also created here. And hope many such programs will increase the awareness of regarding the cholesterol to public, and in turn, public would benefit a lot by such measures. And Reddy's, I think, is not mentioned till now. Is Reddy's also made India proud by making available this new PCSK9 inhibitor, though in partnership with Amgen. I think they have got this injection PCSK9 to our country. And I was just going through in US, and lot of atorvastatin in many of these governmental type of setups in US are also made of Reddy's, atorvastatin. And that's how Reddy's is making India proud across. And thank you once again for Dr. Khanna, Dr. Arunraj, and Dr. Raghu for giving this opportunity to speak in front of you all doyens regarding this topic of cardiovascular risk stratification and get to goal. Because it's slightly behind the schedule, I try to cover up something and try to be brief. And what I intend to do in the coming 15-20 minutes is basically to outline this need for risk stratification, why is it important, and what are we supposed to do in this risk stratification, and what are the various risk prediction scores which we have, and compare each one of them and what is more relevant to India, and take you through the evolution of lipid guidelines way from 2013, where significant changes happened in the guidelines, to present 2019 and 20, where the guidelines cutoffs are further decreased. And then touch upon primary prevention of atherosclerotic disease, and what is the role of upcoming role of CT angio in it, and lipid screening and its recommendations. And as we very apt for us to talk today is get to goals. What are the goals we need to achieve with this? And I want to stress on the statin safety, because a lot of criticism happens on statins, and then conclude in the end. If you see the need for risk stratification, as you said, we are dealing with a very high cardiovascular disease burden in our country. And it's very important for us to identify which are the subgroup of patients which have high risk, which are the low risk, because depending upon it, we can tailor our efforts as well as our resources towards that. If you identify a very high risk patient, then probably allocation of all the preventive therapies and improving their outcomes becomes important. And a lot of new biomarkers are also coming up in the evaluation of this management of this cardiovascular disease. And such things we can incorporate if we know who are the high-risk subsets and who are the low-risk subsets in the things to come. If you see, this is very important for us to see, though you have a pyramid here, the baseline basis of risk factors, some of the traditional risk factors is well known. out of which one of it is very important is dyslipidemia and hyperlipidemia. Apart from it, there's non-traditional risk factors which are sometimes seen in our Indian subcontinent in some young individuals with no standard risk factors are also important. And these are something like metabolic syndrome, which is again which could evolve into diabetes, autoimmune diseases, systemic autoinflammatory diseases, depression, anxiety, social support, show low socioeconomic status, radiation therapy. These are some of the new things which were not marked as risk factors before. Now it is coming up more, especially in the younger lots who suffer with coronary artery disease. And the subclinical atherosclerosis, though we know that the fatty streaks forms very early, and from the school age itself, it is important for us to educate. That's how we were discussing to prevent this occurrence of overt development of disease. Then right from the subclinical stage, then we get into clinical disease of heart attacks or paralysis or peripheral artery disease, then going on to heart failure and sudden death. And then we have some unfortunate individuals who get into recurrent events. So baseline below, control of risk factors will lead to primordial prevention. And then control of this development of the disease is primary prevention, as we know. And we also have some very important roles by the statins and other drugs in the prevention of recurrent events, secondary events. And obviously, the goals will be different for each of these subgroups. If you see what is the step 1 in the cardiovascular risk stratification, is basically to identify the risk factors, because they are the main crux. If you control there, further progression will be avoided. As these are the traditional risk factors, which we all know: hypertension, smoking, obesity. Hyperlipidemia is the interest of choice, topic of choice for today's discussion. Diabetes. Another important thing is premature family history of coronary disease, cerebrovascular disease. And whoever has such very young family history heart attacks, we need to be extra careful and take all these precautions and checkups very early, and a decade earlier than what their parents suffered with that initial problems. Then step 2 is some of these other concepts which have come up, which I briefly touched upon, is the risk enhancing factors. These concepts came up in 2018 guidelines onwards. So basically premature family history and primary hypercholesterolemia, very runs through families, very high lipid levels. And sometimes kids like 12 years, 15 years also get into heart attacks and troubles. Metabolic syndrome is a very important subgroup entity. It actually contributes about a significant number, about half of them if they are diabetics, and another half numbers would be like metabolic syndromes in our country, where you find borderline sugars and then blood pressures on the higher side, and again triglycerides will be higher with truncal obesity. Chronic kidney disease, we now know that kidney disease is also coming up as one of the important risk factors. This is apart from diabetes and other problems. Chronic inflammatory disease, premature menopause. Many times, unfortunately, in India, young females also get into the early hysterectomies and things like that. We'll get into the risk of this. Then this has to be highlighted. High risk race, being Indian, South Asian itself is a high risk factor. That's so whatever risk we have, we need to multiply it to 2 to get the real risk in our Indian subcontinent. And some of these other lipid subtractions like lipoprotein small a and then ApoB, like things are also getting into limelight as we have more methods to assess them. And the biomarkers like C-reactive protein, especially HSCRP, is found to be having a correlation with a lot of recurrent events. That's what the studies show. And that's how we now evaluate and identify and check in some of these patients. Ankle brachial index, again, is an indicator of peripheral vascular disease. It's obviously evidence for peripheral vascular disease. So these are some of the risk enhancing factors apart from the risk factors which we need to know. Step 3 is, again, we know that various age group of patients we have age, gender, female, ethnicities, all this, but we need to again get all this into some country-based things and also individual-based things. United States, we all follow this ACCHA recommendations of a risk calculator. I will touch upon that. Canada has their own. UK has the Joint British Society risk estimator. This is what simulates our Indian subcontinent too. And China has one. Europe has one. We at Apollo, with all this preventive health checks going on, about 25,000 plus data is being collected to formulate officially a probably risk score, which is more particular in our Indian subcontinent. Apollo Group is working with Microsoft to create that. And many such more things are required for which become more particular to our Indian subcontinent. So if you see how we proceed further, this is ABCDE concept, we labeled it just to make it interesting and to people to understand. Assess for the traditional risk factors, that is A, And then baseline risk estimate, what is the risk in that subgroup person, individual, you have to see. Then consider any non-traditional risk factors. In some cases, you also check for biomarkers like HSCRP and things like that. And non-invasive measures like you get a carotid ultrasound or a peripheral vascular disease development and subclinical atherosclerosis evidence, and develop each individual personal risk profile, not only considering the population in general. And that is how that each person's risk has to be again evaluated, and engage in the clinical patient risk discussion. This is very important. As Arul Raj and many others mentioned, patient is the point of interaction, and patient confidence is very important, and you should understand what we are doing is for his good, and then develop into practice guidelines based depending upon the risk category which this patient has. I think this is engaging with the patients and to get a proper outcomes in them becomes important. So assess risk factors, assess the baseline risk, then consider all the risk factors and some of the measures, and develop personal profile and engage with the clinical discussion in the patient, and it goes for a long way in assessing the risk in these each individuals. Taking those into account, actually, lot of risk scores have developed. We are all very much aware of Framingham heart study, which comes out from 90s and is very popular. And though it is has some modifications in 2008 and 98 also. The British Society, many others are Q risk and many other risk scores are there. I won't be touching all the details. I'll highlight little about Framingham's and ACCHA risk scores. The Framingham risk score is actually derived from these risk factors considering age, gender, total cholesterol and HDL cholesterol, systolic blood pressure, and smoking. These factors are taken into to calculate the risk score, and it calculates a 10-year risk of getting into myocardial infarction and cardiac death. And individuals with 2 or more risk factors are considered to have their FRS, this we should calculate. And anybody who has more than 10-year risk of getting into more than 20% into trouble is called high risk, and less than 10% is called low risk, and 10 to 20 becomes independent in mid-range. So it's whoever has the 20% or higher risk becomes high risk candidate. That is about Framingham risk. If you see ACCHA risk calculator is important for all of us to understand. It has come even in the smartphones and other things. We need not mug this up. But basically, it again depends upon sex, age, race, and total cholesterol, HDL cholesterol, systolic blood pressure. And the treatment is on. Diabetes mellitus again is given importance, and smoking. Depending upon this, each of the person will find out his risk now, and also what is his future risk of developing the trouble later in the life is known by this risk calculator. If somebody has 7.5% or higher further, it directly goes to the increasing risk. Then the primary prevention, considering the Framingham risk and ACC scoring, what is basically seen is whom are the patients whom to screen for dyslipidemia. As we said, those are all the guidelines scores. But you have obviously evidence of atherosclerosis, or already has aneurysm, diabetes, arterial hypertension, smoking, and stigmata of dyslipidemia. Sometimes if you do general examination, you could get xanthelisma, xanthoma, and family history of dyslipidemia, chronic kidney disease, inflammatory disease, erectile dysfunction, obstructive disease, hypertension. All these are pointers for us to screen for dyslipidemia too. What do you do? Basically, apart from history and physical examination, you do the total lipid profile checkups, and also try to concentrate and see non-HDL cholesterols apart from LDL alone, and glucose obviously, and EGFR. Optional ones are albumin estimations and ApoB estimation. Non-fasting is also accepted of late as just if you're not considering triglycerides alone. And if you see the various risk scores, like apart from Framingham risk, which I've touched upon, and ACC, WHO risk and JBS risk scores almost are similar, but WHO risk actually highlights the risks a little more than all other risks. But it suffices for us to say, being Indians, we need to assess our risk proper. As I said, being South Asians, Indians itself is prone for disease, and we need to multiply our risk compared to standard risk by 1.5 to 2 times. And that's how we tend to get risk assessments for Indians. I would touch upon some of this evolution of these lipid guidelines and the importance of statins in this, because this is relevant to our country. And also what I would say is this 2013 onwards, what these 4 subsets which gave for the benefit of statin is very relevant, and all of us should always recapitulate an lipid discussion on this. So which are the subgroup of patients which benefit maximum by using statin therapy, especially high intensity statin, is this. If you already have evidence of atherosclerotic disease, be it carotid, peripheral, or coronary, anywhere, then you have a very high positive benefits with usage of high-dose statin. And if you did not get disease already, but you have very high LDL cholesterol, so more than 190, always people used to have discussions on this. I didn't have disease, but cholesterol is this much, whether I need to take treatment with statin or not. This has thrown clear guidelines. More than 190 LDL cholesterol became benefits again maximum. You don't have to add such a high cholesterol, you don't have a disease already, but you have diabetes. Again, diabetes is a killer disease. Diabetes, even with lesser levels of LDL cholesterol, again, it becomes important for us to take treatment with statin. And you don't have any of these, but you have a future chance of getting into atherosclerotic risk of more than 7.5% by those risk calculators what I mentioned, then again you need to take statins and you will benefit by this. So these 4 subsets are important for us to remember. And if you have to have the habit of playing cards just for remembering Ekka, King, Queen, and Jack, what I call. So King indication is basically already evidence of cerebrovascular disease, and then others are other 3 are follows. So basically we need to remember these 4 subsets which benefit by statins. How to treat these patients? By high intensity statin. High intensity statin is again, we always used to have cutoffs, targets before, but this modification in this showed whatever values they have, if you decrease it by 50%, that is what is high intensity statin. And if you decrease it to 30 to 50%, it is moderate intensity statin. And high intensity statin, you can only be done by rosuvastatin 20, 40, atorvastatin 40 and 80. If you do very small homeopathic doses of 5 milligrams and all, it won't be effective. And moderate intensity is what is listed here. Then if you see further in 2018, there are more highlights on even not only on secondary prevention, and primary prevention is also highlighted. Some of the things to see in secondary prevention, apart from the age group, which falls into higher age group, will becomes a indication for treatment. Very high risk of disease is what is introduced from here onwards. Let us briefly see what it is, and also concepts of adding SDMIB and PCSK9 inhibitors along with statins is introduced in this very high risk group. Very high risk for future events is because patient has recent ACS, MI, stroke, and symptomatic or peripheral vascular disease, and had already revascularization or amputation, becomes very high risk. And some of these other high risk features are what I touched upon briefly, like CKD, diabetes mellitus, and heart failure. These again becomes high risk for future events. Then primary prevention, again, when you are dealing with subsets of patients, which subgroup the patient is falling, and how much benefit you will have by having these primary prevention goals, we need to assess and accordingly decide. This is the primary prevention pathway is also highlighted from 2018 onwards from these guidelines. Apart from the standard top 4 right ones, which have a high intensity statin benefit, that is, again, to recapitulate, LDL cholesterol very high, diabetes mellitus, and then probably atherosclerotic disease already. And if you do not have this, and if you fall into intermediate age for age groups, risk groups, less than 5 is low risk, then probably you can follow up. These in between 5 to 7.5, and then 7.5 to 20, and more than 20% Framingham is again fall into the importance of statin. And this is where in intermediate risk, you also get the importance of usage of coronary artery calcium, which we CT angio is becoming very popular. High risk, anyway, you straight away put them on treatment. Low risk, again, you follow up. The borderline intermediate patients, you can subject them to coronary artery calcification, CT angiogram, and depending upon what comes out of it, if the calcium score is more, then probably you need to be aggressive on controlling this. And probably we doctors also are careless sometimes. So we are collecting the data at Apollo that how many of the plaques demonstrated in the calcium scoring and others could be treated, and we follow them up. And if it suffice to say that if he has falls more into high risk category of more than 100, probably high intensity statin therapy should be given. That's how I think CT angio also is playing its role in the preventive benefits and prevention of this disease. And as the topic of today is get to goals, we need to understand what are our targets. Though we say total cholesterol and LDL cholesterol also there, but LDL cholesterol is the worst thing which gets into trouble. That's why all the guidelines stressed upon what is the target levels we need to achieve. We were little liberated before in 2016, and we became very stricter in 2019 because we came to know that you decrease it further up to less than 55, especially in very high risk subgroups, then probably you will have more benefits. So very high risk subgroups is what I mentioned already, who already had an event and heart failure, CKD, things like that. And then in that subgroup of patients, we need to get LDLs to 55. So if it is just a high risk without that, the previous value of 70, moderate risk is 100, and low is 116 or 130, some people used to mention, is what is recommended. It is very apt for us to understand that just starting therapy is not enough, and we need to achieve those. Sometimes when you're not able to do this, that's how the 50% reduction concept of high-dose statin came in, and you need to achieve that, especially when the values are lower. This is what Dr. Khanna was mentioning and asking about the Lipid Association of India statement. Those statements were issued in 2016, as well as again in the recent, again they've come out with a modified statement showing that because we Indians have slightly higher risk, what they said is very high risk, what European Society said as 55, they decrease it further, and what we need to achieve in India, according to Lipid Association, is less than 50 milligrams per deciliter of LDL cholesterol. And if high risk is less than 70 and moderate risk and low risk is less than 100, is again stands hold good. And it's also, they have stressed up on non-HDL values, because sometimes triglycerides also are a little abnormal in our country. We'd have more discussion in our discussion point. Then other things which are very highlighted in the secondary prevention by 2019 European Society guidelines is adding ezetimibe and the class 1 indication if their values are not achieved, and adding a combination, and also introducing PCSK9 inhibitor is also recommended to achieve those target levels, class 1 indication. Then if a patient has recurrent events, then probably you tend to get into a level of less than 40. And acute coronary syndromes, the more higher the risk, the more early starting this drug will benefit. So in these high-risk individuals who have suffering of the recurrent event, that's where I think we need to take the help of PCSK9 also, where because routine statin and ezetimibe may not be achieving those such low levels. And this is another form of expression of European Society guidelines and the targets what you get. So basically, wherever there is red falls into, they are high risk, and we need to take help of high-dose statin therapies and get into those target values which are mentioned and get to goals as what we are discussing today. And this is again a different form of expression to show what are the target levels depending upon the baseline condition which the person has. We decide upon the targets. If you see patient has diabetes mellitus and always already has evidence of cerebrovascular disease, then we becomes a very high risk candidate. And extreme risk, our target level is less than 55, as what we mentioned. Indian Association said this as 50. And if you did not have a disease already, but you have diabetes, then probably you can go with moderate into the statin, decrease of 30 to 50%. I think we can have more such discussion on individual subsets. For the sake of time, I would skip here. But it is basically to highlight that depending upon the baseline disease which each individual has, we decide upon what needs to achieve, and at least achieve what is the best possible, and not only with the take of help of cytostatin, and probably take of help of ezetimibe and PCSK9. Because I see a lot of criticism coming on statins, I wanted to put these 2-3 slides which are strongly favoring this. Statins are poised to perform greater wonders in the 21st century than antibiotics did to infectious diseases, and H2 antagonists and PPIs did to peptic ulcer in the 20th century. Though now, when we were students, actually, GJ, vagotomies and all were very common. It's all gone because of PPIs. Statins, though, they are not able to abolish CAD totally, but are very powerful methods for us to control this rising epidemic of cerebrovascular disease and coronary disease. Regarding the safety, a lot of criticism happens. It does that to myopathies and all that. But if you see what are the various drugs we use, aspirin, which is very commonly used, statin therapy is 10 times more beneficial, safer than aspirin. And then if you see diabetic medications, many of them like hypoglycemia-prone medicines, statins are 100 times more safer than this diabetic medication. That's how it is. We need to highlight these aspects. And as the ancient proverb goes, superior doctors, we need to prevent the disease, and mediocre doctors generally treat the disease before it's evident. Inferior doctors treat and putting the stents and surgery. All of us should aim to prevent the occurrence of disease and become superior doctors and help these patients in getting their positive outcomes. Thus, to conclude, what we need to do is basically, we all know that CVD is on the rise in India, the leading cause of death across the world. And we have seen various risk assessment tools, risk assessment tools like be it Framingham, ACCHA, WHO, and lipid screening is important again for us to understand and to control this. And evolution of lipid guidelines, how to control target levels, what is saying, I would stress upon this line. All of us need to concentrate here. Previously, we used to think lower is better, and we wanted to get it to lower levels and maybe less than 70, 100. Now we say in between, we are saying lower only is better. We need to anyway get it to lower levels. Don't be happy with whatever lipids you targets you had. And now we are going to the step ahead, showing that lower than lower, that is ultra low lipid levels, which could be possible with PCSK9, could be the future. That's where the regression of atherosclerosis happens. Unless your lipids go below 40, regression of atherosclerosis is not noted. So this is probably in the era in future we could take more aggressive and levels of treatment and could get into regression. And statins, I would say, is very safe and effective both in primary and secondary preventions. And all of us, many such programs would put in and go a long way in preventing primordial preventions and primary preventions and prevent the rising burden of CVD in our country. Thank you again. I would like to thank all the doctors, 3,500 cardiologists who logged in for this TCT meeting recently. Why I wanted to project is basically to bring your attention all those encouraging lectures which we all had is on VOD mode in the TCT India platform. All of you can download. Another initiative from a fax group, what we made, Kanna will be interested to know, is basically to educate doctors and medical students. We created this online platform of training students by these super specialists, because COVID times they're not able to go. This is another newer initiative which we started. Thank you again for all the patient hearing, and we can have more discussion. Thank you.
Thank you, Dr. Sreenivas. Really very enriching, as expected, very succinct, very contemporary for dyslipidemia management in today's times. Thank you so much for that, and the message is very clear. We have to stratify the risk. We have to get to the goal, and we have to treat dyslipidemia very aggressively, and lower the better. Thank you so much for that succinct lecture. And now I hand over to Dr. Usha from Dr. Reddy's to preside over the panel discussion with our esteemed faculty here. Over to you, Usha.
Thank you, Dr. Kumar. So thank you, Dr. Sreenivas, for explaining us the importance of risk stratification and telling us that risk stratification has to be started as early as possible in the patients. So our first question would be, as we saw that there was changing trends in the goals of the lipid levels, be it in ESC or be it in ACE guidelines or be it in the ADA guidelines. So what would be the reason for this? Is it because there is more awareness of the cholesterol among the general population, or is it because there is less hesitation day by day among the physicians to bring the cholesterol down by using more of the higher statin? Or is it that we are having more of the evidence coming up?
Yeah, that's it. Actually, guidelines evolve depending upon the data, what we find in the various studies, you see. Once we became aware that LDL's reductions, we were previously targeting only LDL reduction of less than 70, where we were not able to achieve regression. Now, once we came to LDLs of less than 40, are you able to hear me? 40,
yes,
then that's where regressions are happening. Once we started using PCSK9 4-year trial and other things where LDL cholesterols were further low, then we became confident that decreasing LDLs to less than 40 also is still safer. At birth, our LDL cholesterol will be around 40. So that's how we became very confident that aggressive reduction of LDL now is safer, not only safer, but it has a potential to regress atherosclerosis and prevent occurrence of recurrent events. That's how the guidelines we are coming into evolving, decreasing the values further and further. It's not because just we want to promote only Reddy's atorvastatin, we are doing it. It is for the patient's benefit, the recommendations come like that. And as the data comes up with a more high-dose statin therapy and more PCSK9 inhibitor trials saying that ultra-low LDL reduction, we are going to that step now. And that's how, and we also know now which are the subgroup of patients which benefit by doing that. Very high-risk category is again created from 2019 onwards. So these high-risk subgroups, especially at least in this subgroup, if you can target to get such low LDL levels, it will be useful for the patients to prevent the recurrent events.
Yes, thank you, sir. So my next question would be to the panel members, along with the speaker of today. So the question is, we are concentrating on LDL-C. What about the HDL? What about the HDL? How much the optimal HDL level we need to look into? should we concentrate on HDL or we should concentrate only on the LDL levels here? Taking into account the pleiotropic effects of the statins as well.
Raghu sir, you want to answer that or shall I take it? Raghu sir is planning to talk. Let him.
Yes, sir.
Now over to Sreenivas. I think after that, anything to be added, I will add up.
Okay.
Sure.
Dr. Raghu, you want to tell anything? Shall I? Kanna sir? Yeah.
Yes, Dr. Khanna.
You're able to hear me?
We are able to hear you.
Dr. Sreenivas, you carry on, and if there's anything more, I'll add.
Okay. So HDL is also equally important apart from LDL cholesterol in the disease pathogenesis. Not only the pathogenesis, but for protection of event, because this is supposed to be a good type of cholesterol which removes the cholesterol from the plaque getting deposited. But only problem is anything when you tamper the nature too much, boom, it boomerangs. That's what happened with Serivastatin when HDLs were increased up to 90. So what we now target is to have HDL cholesterols in somewhere in between above 55 and 60, not more than that. And it's not easy also to get it. And many of my colleagues, including Kanna, would be happy taking help that probably alcohol helps in increasing HDL cholesterol and stuff like that. But none of the Indian studies were very potent in increasing the HDL. It's not easy to raise HDL cholesterol because if you do continuously exercise and a significant amount of exercise, and then probably in the long way, taking very little amounts of alcohol, Mediterranean climate showed some improvement, not in India. So it is not easy to increase HDL cholesterol. And these drugs which we have, when the total cholesterol comes down, what we need to understand is the total HDL level also could come down along with the total cholesterol. So HDL is a part of total cholesterol. But the ratios should be maintained. That's how it is important. So what we need to educate patients is they need not be worried if the cholesterol HDL levels also come down a little, but overall ratios are still maintained. But if you have to have increase in HDL cholesterol, very aggressive athletic type of persons, and then probably doing very high levels of competent exercises are supposed to be described to increase HDL cholesterol, which is not very easy. And one thing very reassuring is, if you need not take it to very high values like 80, 90, it's not possible. And it is supposed to having some of the negative effects again if the values go high up. So if it is less than 40, you are definitely at a higher risk. 40 to 50 is what is commonly seen in our country. But if it is more than 55, it is a protective factor again for prevention of future events. If you can get to those levels, it is always a welcome. But it is not easy to increase HDL cholesterol. Out of the statins, what people ask is which statin has the potential to increase HDL, which has to decrease LDL. Both atorvastatin and rosuvastatin could have it, but probably rosuvastatin has a slightly better potential in not decreasing total HDL cholesterols slightly, or ratio-wise, slight increase is noted. But overall reduction of LDL is what is more important.
Thank you, sir. So, Dr. Raghu, do you have anything to add to Dr. Sreenivas' answer?
Sreenivas Kumar has covered everything.
Yes,
Only now there's a lot of interest on coming on ApoB, I think. ApoB, I think earlier we used to measure only LDL, HDL. Now I think they are
That is because of triglycerides also. In Indian subcontinent, people feel that triglycerides are also important. High triglyceride levels. But what I would like to say again is, if somebody has 150 to 200 triglycerides, is not as dangerous. But if triglyceride levels are crossing 201, as what is seen in many of the trials, and especially when they cross 250, that's where risk starts increasing. But we always need to see whether any secondary problems which are causing these high triglycerides, like uncontrolled diabetes, hypothyroidism, or any other causes which are leading to high triglycerides. In that case, if the triglyceride levels are more than 250 or so, don't be happy just by giving statin. You could take the help of, now we have got other data coming up with icosapentaenoic acid, and also we had fibrates before, but fibrates were not that greatly effective in decreasing mortality. That's how they became out of popularity. And saroglitazar is another drug which came to decrease the triglycerides along with LDL cholesterol. So, but predominantly, I would say it suffices if you address total cholesterol and LDL cholesterol predominantly, not to keep triglycerides very too high levels.
Yes.
Is there any concern of higher the dose, there is increase in incidence of diabetes? Because though Jupiter trial showed, that is the only trial showed probably the diabetes incidence increases.
This is very important point, sir. What I mentioned also is it's our duty to remove these apprehensions and doubts about high dose statin usage from the minds of various physicians and patients too, because many of them it's easy to criticize. This point is discussed and researched in detail about the new onset of diabetes and how the sugar levels went up a little with high dose statin usage. This was started first from Jupiter trial where the sugars were little high were noted. But what is very heartening to note is now the meta-analysis, what they showed is if the risk of increasing sugars is 1, the benefits is 9 times. So the risk-benefit ratio, it is 9:1. And even in the subset of patients in which sugar levels have gone up a little, still the mortality is reduced even in Jupiter trial and all of the subsets of patients in which it is analyzed. So don't go by absolute value of sugars if it has gone up by 510 milligrams per deciliter. But overall mortality is decreased even in those subgroup of patients in which sugars are elevated. So you need not worry about little increase of sugars with statin therapy. But only thing is in subset of metabolic syndrome where you have borderline sugars, we need to keep this in mind and keep a watch on sugars. That's all. But benefits are should not be denied with this worry of sugars rising.
Thank you, sir.
Okay, thank you.
So I asked Dr. N.N. Khanna and Dr. Arul Raj if they have anything to add to this question. If not, we shall move on to our next question, which is specifically on.
Can you hear me?
Yes, sir.
Okay, so Sreenivas has explained it very well, but I'll just add few points. Now coming on to HDL, now as he said, HDL can only be increased by exercise, a little bit by alcohol, and maybe the drug which we use is niacin. Now there have been a lot of trials actually raising HDL by niacin. It does increase your HDL cholesterol, but the side effects are too many, and many patients won't tolerate it because of diarrhea and flushing. And the type of HDL which is increased is supposed to be not protective. So you may have increased number, but it's not a protective HDL which actually is beneficial. So niacin therapy is probably of no use, and that number of increasing, getting up to in numbers of HDL is again not a good idea. The only thing you can do is exercise, number one, and second is statins to some extent may increase and make the ratio better, but these are the only two things, and the main focus should be on lowering LDL rather than increasing HDL. So that is the most important thing. And the second thing is again, when we are talking of triglycerides, triglycerides alone may not be a great risk factor. Triglycerides up to say 250 again may not be treated by fibrates, phenofibrates, or specific agents, but anything above 250 in presence of dyslipidemia can become a very major risk factor in India, and they have to be treated with specific triglyceride reducing medicines. So these two are important. And again, as he has said, meta-analysis showed Jupiter trial actually brought in this issue of having diabetes and with statins, but there was a lot of hype, and it actually became so counterproductive that many physicians and people started either stopping taking statins, or they stopped taking statins, or actually they reduced the dose. But most of the meta-analysis, there have been 3 meta-analyses, all of them have clearly indicated that this is not a statistically correct derivative, that in general, in all comers, that actually the high doses of high intensity statins will actually increase your sugar significantly and make you from a stage of pre-diabetic to diabetic. So, and as it is, even if you go to that level, whether it's a disease progression or it is because of statin, we don't know. And even then, the benefits are so many that this drug has to be given. So that fear should not be there. And now coming on to the LDL levels and to lipid levels, again, as he said, if you are born as a child, your lipids are less than 40, 50, they are in 30s, 20s. And probably the future goal of therapy would be at that level. We may even in future go to single digit LDLs, and that may be the final lipid goal. And we are not far away with genetic therapies to achieve that goal. And although it will be limited indication for it, but I see in future that will also be one of the goals, and it will be easy by either monoclonal antibodies or interventions.
Yes, sir. Thank you for that question, sir. So, answer. So, we have one last question to take, which would have three parts in it. One is whether the risk stratification is followed strictly among the physicians, and if followed, which is the risk stratification tool they use. As Dr. Srinivas Kumar mentioned, JBS holds good with South Asians, where the Indians are also involved. But clinically, what is the scenario? And if the risk stratification is done, the second part of the question would be, if the risk stratification is done, would the administration of statin differ, the choice of statin differ based on the patient profile? For example, say there is a patient of 65 years old female who is diabetic, and would your choice of statin differ there? So,
As I
yes,
mentioned,
sir.
basically, if a patient has diabetes itself, he stands a very high risk. So he needs the benefit of high dose statin. And then if patient has evidence of cerebrovascular disease, already has coronary artery disease, MI, unstable angina, peripheral vascular disease, anyway, he needs to take high dose statin. That's why I try to highlight those four specific subsets which benefits with high dose statin. And if you do not have any of those four, then the risk stratification comes in, where if you have a risk of developing into trouble more than 20% with Framingham or more than 10% by the ACCHA, then you take the help of high-dose statin therapy. If it is in between 7.5%, less than that, then probably low-dose statin you can use. If it is very low risk, then just by the lifestyle modification, other things you could try. So, but for the various risk calculators, if somebody has to follow it, I think many of the smartphones have ACCHA risk calculator, which is very easy for anybody to download and use it. You need not mark up what is there. You enter the patient's data, you get the risk of that patient. I feel that that can be followed. Though in India, we have little more importance of HDL cholesterol, and in Apollo, the whatever risk calculations which we did in this life risk score which we are trying to get, then importance was also given for diastolic blood pressure. We are noticing, and inactivity, physical inactivity in patients also it's becoming one of the important component, which is not there in any of the world risk scores across. So this Apollo risk score, if it's validated further, it might have these two other additional features which are not there in the traditional risk calculators. That is diastolic blood pressure being high, and the prolonged sitting or lack of activity could also be one of those important pointers to develop increased risk. But what is first to say is, whatever the risk, use some dose of statin, because again, people should keep sitting and criticizing that they don't want to use this because it causes that to this. If that is gone, also will do a lot of good to patients. And it's many such. I feel worries on statin therapy, on the lipid therapy, should be removed from the minds of patients, and also many of the doctors also need to be educated further regarding the safety of high-dose statins.
Yes, sir. So just one addition to this last question, so where the female was 65 years old, she is diabetic, but her LDL-C is 40. This is the question which we have received from the audience. What would she need statins here?
Basically,
and how is the scenario that the 40 is her LDL-C? Yes, sir.
Yeah, they basically, as what I initially highlighted in the discussion, in India, we don't see very high lipid levels sometimes. Okay, lipid levels could be borderline, but still the patient should suffer in event. So whatever the lipid value, that itself is abnormal for that person. That's how he has suffered an event. Okay, that's how it is. The modified forms of recommendations where 50% reduction from the pre-existing value holds good for such individuals in which levels are low. So that's how latest guidelines, when they said very high risk, you decrease it to less than 50 in India, or 50% of a pre-existing value, whichever is lowest, we need to achieve. That's what is the thing. This lady who is postmenopausal, again, women lose the protection, whatever once they attain the menopause. So there is no more protective effects is gone. And postmenopausal female with diabetes, okay, The information is lacking on whether they already suffered an event or not. If she suffered an event, definitely she needs a high-dose statin therapy. There's no doubt in it. If she has not suffered an event, then probably you could give, because people could argue the LDL cholesterol is less and she doesn't have an event. That's where you could give even a low dose or moderate incidence dose of statin. But being diabetes itself stands a high risk and needs the benefit of statin therapy, be it whatever be the lipid levels. One point I want to highlight for the benefit of listeners, everybody, is many of them tend to see how long we should give, we will decrease the medicine. Okay, apart from the cost factor, which Reddy's and others obviously should take it account to benefit of patients, and there is no hurry to decrease the dosing of statins. The high-dose statin benefit, it should be given as long as patient is tolerating it. And the benefits are not only digital reduction of values of cholesterol, but it has non-lipid lowering benefits, like what we call as pleiotropic effects, should be given to the benefits of a patient's long-term therapy. And we need to understand that if you do exercise, you will get the benefit. If you eat only, you will get energy. Similarly, if you take tablets only, you will have the benefit. You can't expect statins to continuously do benefits after stopping the statin therapy. So it is better to continue statin therapy lifelong if possible, unless there is some side effect or problem with the high-dose statin therapy. What is recommended is when 2 successive levels, 3 months apart, of LDL cholesterol values are less than 40, that's where you can tend to decrease the statin dose a little. But if patient has no problem in purchasing and no problem with side effects, it is better to give the benefit of high-dose statin the longer possible, and if preferably lifelong.
Thank you, sir. So do we have any last comments from our panel members, Dr. Arul Raj and N. Khanna, Dr. Raghu, sir? So.
Okay.
So I think we are very clear, sir, as to how long the statins have to be given and how important is the risk stratification. And very important point to note is to maintain the ratio here. So with that, I thank you, Dr. Sreenivas Kumar, for your excellent presentation here. And now I would like to hand over to Mr. Alok for the closing.
I think Reddy should also take every opportunity to educate doctors about your wonderful molecule injection which you brought it. That is PCSK9 injection. Though in collaboration with Amgen, it is a wonder drug, and if used, it will decrease the cholesterol values drastically, significantly with the 2 doses itself. But the problem is again the cost, and the problem is again if you stop it, it tends to rise. So, but every opportunity I think you people should take to highlight that you have this molecule. I am not worried about what division it matters, and I don't know which division of Reddy's makes it, and we're not talking, and all that is different. But you have such a potent molecule, we should highlight the presence of it in every forum, I feel. Thank you. Go ahead.
Thanks.
Thank you, sir. So, good evening, doctors. I'm Seth Verma. And first of all, I would like to thank Dr. Arul Raj, Dr. N. Khanna, Dr. T.R. Raghu, and Dr.A.Sreenivas Kumar for their valuable time and contribution for this iconic event. I'm sure that your association with us in spreading awareness on cholesterol goals shall be highly valued. As you all know that at Dr. Reddy's, we believe that good health can't wait, and we always keep patients in the center of all. This National Cholesterol Month will help us to spread the awareness on cholesterol goals. As this is a National Cholesterol Education Month, sir, we are going to have 2 more national level events on 5th of September as well as 26th of September in association with API, APVS, and ICC. We are going to be the part of all upcoming events for the month. We also like to thank all 3 reputed bodies for helping us make this program possible. Last but not the least, we thank all the speakers, panelists, and all 2,000 plus doctors across the country who is watching this entire event for their presence and today's program. So thank you very much, sir, once again, and good night to all.
Thank you.
Thank you.
Thank you very much. It's been a pleasure to be with all of you.
Thank you.
Thank you, sir. Thank you for your time.
Thanks.
Thank you.
Thank you.
Thank you.
Thank you, everybody. Thanks.